So hi, welcome to Muscat Endoscopy Academy. So today we're filming this from Gothenburg, Sweden, and I'm here with my dear friend and colleague, Dr. Yasser, gastroenterologist.
Hi.
Hi Yasser, how are you doing?
Good. How are you?
So we have a 49-year-old gentleman who presents with a referral due to rectal bleeding, and he has a history of some polyps that were found on a previous colonoscopy that was done, 6 years ago, he said?
That's correct.
Yeah, right. And patient has not had any other alarming symptoms, and he has colorectal cancer going on in the family, but not first degree relative. So the point of this case is to do some sort of a screening, as well as try to see whether we have any new polyps that we should remove, and then decide whether the patient needs any surveillance anytime soon, or if he can just go back to the regular screening of the general population. So Dr. Yasser is on the scope right now, and we're going to talk a little bit about technique as he goes, and then I'm going to hand over the mic to him and have him describe to me how he thinks and his strategy when he's performing colonoscopy, so he can take over, Dr. Yasser.
Absolutely. So right now we have passed through the rectum, which is the first stage in the colonoscopy. In this case, we use a water immersion, so we instead of using air, so we insufflate with water and trying to use right rotation, and then by advancing through the sigmoidum.
Right.
In this case as well, it's very preferable to use water. As you can see, the cleanness of the bowel, it is not very optimal. That would help even for inspection during extubation.
Right.
So far, we have not seen any abnormalities. We keep rotating, and a little bit of torque. It's very important to try to visualize where the next destination of the lumen. This is very critical in this area, especially if you have a patient that's previously done a colonoscopy that's been reported to have been painful.
Yeah.
Due to the risk of previous diverticulosis or diverticulitis.
Right.
One thing as well, it is very important to keep the scope lubricated, as a patient unconsciously can try to squeeze through the scope.
Right. I really like that. I think this is, most people actually forget about this. That a lot of patients get a lot of discomfort from having a dry scope around the anus, and it's really important to actually lubricate it regularly as you advance. It's a very good tips while doing endoscopy. And maybe we can say patient is on his left lateral, and he's received a minimal amount of sedation and some Buscopan as well to slow down the motion of the peristalsis of the intestines.
And we do have one-to-one correlation at the moment, and we have now passed through the sigmoidum into the center colon. In these cases, I have now built a little bit of loop outside the colon, outside the patient. So as long as I have a good, clear correlation, I usually try to correct that loop.
Right.
So now I have no loops inside or outside the patient.
Right.
In this case, I try to make sure that I clean the area sufficiently to see a good visualization.
So, in terms of Boston, what would you give this? Like the Boston Bowel Prep score, what would you give this area?
I mean, right now it's very difficult with visibility, but
it's possible to clean and suction.
Exactly,
right?
Yes. So it's
a 2.
It's a 2, exactly. Yeah. But as long as you insufflate, it will be much better.
Yeah.
And now we're using minimal insufflation.
I think that's preferable usually. Now we switch the patient to the supine position, and we have like about 40 centimeters in the patient, I think. Yeah, 45. And I think we're somewhere around the splenic flexure somewhere maybe, right?
Correct, yes.
Yeah.
So now we have good lubrication 1-to-1. I would like a little bit of lubrication. And now we're going to, I usually try to, Ivan, is it possible for you to take a deep breath and breathe out? That's fine. Perfect.
It's very interesting to see different endoscopists usually use different tricks to pass through certain areas. Dr. Yasser is one of the proponents of using the breath technique, which actually works really, really well by pushing the
one more time,
the colon down.
And
as you see here, we're passing into the transverse colon.
Well done.
And you can just pass right through the whole transverse colon really without causing any issues or any loops.
And then now I decrease the stiffness of the scope.
Yeah.
Before I use the breathing technique, I usually try to stiffen the scope.
Yeah. So, and now if we see, where are we right now? This is the hepatic flexure, right?
Exactly.
Yeah. And I think you have a good scope there, and
I usually try to do one rotation here.
So Yasser is doing now. He's doing like quite a bit of torque, clockwise torque, to see if he can get around this angle without having to push. Sometimes it's quite difficult to do that in the right colon and the hepatic flexure because it's pretty wide. So usually what I try to do here is I try to reach the hepatic flexure, go there, stay there for a second. Let's get to the hepatic flexure, and you stay there for a second, and then you just try to identify where is the next, where are we going next.
Exactly.
So I think it's like around 1 o'clock or maybe more like 3 o'clock, and something just need a little bit of torque, and then work with your wheels. And then really you don't need to push much, but rather like withdraw your instrument and suction, and then you end up right in the middle of the right colon.
I usually use a dolphin technique, basically, actually.
Jump right in, huh?
Yeah, no, as in like navigate up and down, up and down, up and down until you see like this.
Never heard this one before, dolphin technique. Very nice.
I think I made that.
Is that you made that up?
I think I made it up, to be honest.
Very nice.
But now look, we're successfully.
It's very nice. So it's like many successful ways of dealing with this. We already see that we're almost approaching the cecum here, but
now we have the cecum.
Yeah. But we need to go in there and see what's up.
This is we need a little. Can you take a deep breath? And even more, and then breathe out. Well done. And now we are here. So now what I usually do is, can we increase the water to 10? Thank you very much.
So we've reached the cecum, and we'd like to see.
Thank you.
Like to see every little bit of it, right? I mean, this patient has had the history of cancer in the family, We need to make sure that we see the appendix properly. So what is your strategy to visualize this whole area and make sure not to miss anything?
Just in the right colon and cecum and cecal ileocecal valve, there are different techniques. If you do have a good visualization on the supine position, then I usually stay on the spine position.
Yeah.
But sometimes just behind the ileocecal valve, there is a difficulty visualizing there.
Yeah, exactly. Sometimes that's that. And what do you do in these cases?
In that case, I usually either rotate them to the right or the left.
Yeah.
So rotation
one nice idea to always see, like, this whole area is either by putting the patient on the right, because then you're going to have the fluid move away from the cecum, and the gas piling upwards, which actually allows you to visualize it nicely. So what Yasser is doing right now, he's doing something called water exchange technique, where he's basically flushing in water while, like, suctioning, like, the less clean remnants in the colon, which is a very, very nice way of actually seeing the colons. I really like that.
At the same time, I'm insufflating some air because it's very important to visualize this area.
So one thing is, either the patient can be on the right, or you can have the patient back on the left, and then you can do retroflexion in the cecum, right? Yes. Retroflexion in the cecum, in my opinion, is something that should be done in almost any endoscopy. So we're looking now, trying to see, I'm pointing to the screen, I think I see something small to the right of the appendix, but it's really hard to tell. Maybe if we switch to MBI, we're going to get a better...
to insufflate and then clean the camera, and then we can switch to MBI. And here is just, you do have to change position of the patient at some point to see all the angles. Then you just go inside them.
You see, like, the folds of the terminal ileum there.
I usually tap the air.
There we go, right in. Very nicely done. And it's very important to remember all, like, the landmarks and, like, the photo documentation of the landmarks. So usually what I try to do is make sure that we take at every part of the colon and small intestine that we're examining, take something. You can see an aphthous ulcer here that is solitary. So, and when we see something like that, it is not really that worrisome. I mean, it is usually an indication for us to try to advance a little bit farther in the small intestine to see if we have more of them. But if you see one solitary aphthous ulcer like this, what would you be thinking?
This is usually unspecific and most commonly related to inside or sometimes post-infectious.
Right. Right.
It is not your classical IBD or Crohn's.
Is that the same one there to the right, or is that?
No. This is only one here.
No, there's two. There's one there.
Exactly, three actually.
There's three. So 1, 2. 3. If we go right in there, let's try to have a look. So now that we've seen like maybe 3 or 4 of them, what would this strategy be? Do we just consider them, right? Do we just call them NSAID ulcers or unspecific, or do we biopsy?
I usually biopsies all the ulcers. I mean, I've never seen any case of anything that's malignant, but I mean, in the worst case scenario, it is low active IBD.
Yeah, low active Crohn's, right?
Exactly.
Yeah,
and even these, they don't need to be treated, but at least we have
a diagnosis, right? Because it might have some other implications for the patient.
Exactly.
I mean, he's not in the age where we need to be thinking about other problems, but they have been talking about, like, some sort of fissures and stuff like that in his anal fissures in his referral.
Yes.
So there's actually, like, start, like, kind of, they start to put 2 and 2 together. Okay, were they actually fissures, or were they like small fistulas? What is it? Because If it was a small fistulas and then you have like these ulcers, then maybe you start thinking more likely to be Crohn's disease than anything else, right? But so it's really like, an ongoing dialogue with yourself as an endoscopist as you see those things. It's like, what is it that I'm looking at, and what is the best course of action? Because you cannot biopsy everything you see, because if you biopsy everything you see, you end up with loads of unspecific findings that you don't know what to do with. But if we try to put the clinical picture together, and piece it together like a small puzzle, probably we start taking more targeted biopsies in cases where it actually matters, and that's when we actually catch the patients that have some diagnosis that might not be too active, but it is still a diagnosis that they need
to be followed up.
Yeah. To me, they don't look like Crohn's ulcers. They're pretty solitary. There's not much edema going on around the area. The whole like ileocecal valve seems totally normal. It's usually like it's patients that have IBD, even low active Crohn's. They usually have a little bit of an issue with the IC. I usually tell many endoscopists is that I've learned from some of my mentors is that sometimes you need a third hand.
Yes, definitely.
Because and that's when asking the nurse or the assistant to hold the scope is a really really good idea, so that you can actually work with your wheels and you can work with your biopsy forceps, because you need that third hand. So many endoscopists are not used to asking the assistant to hold the scope, and I think we should do it more often, especially when you're doing therapy and things like that. When you actually need that precision, it's really really beneficial to have somebody hold the scope for you. So hi, Dr. Yasser.
Hi.
Very well done during this procedure. We've spoken about technique a little bit offline. The only thing that maybe we should revisit here is polypectomy and polypectomy technique. Something we talked about a little bit when we were in the room and on the recording, but I think it's nice to deconstruct this little part. A lot of people are so obsessed with removing the large, cool polyps. But it's actually, I believe that removing the smaller polyps in a very nice and efficient way will actually only pave the road to being able to doing much more difficult polypectomies and resections. A lot of people just look away from. So before we start playing the video, how did you think like you looked at the polyp, you found it? What was your initial judgment of that?
I mean, it is low-grade dysplasia out of the optical analysis.
Right.
I mean, in this, the percentage of this is happening to develop to something malignant, possibly is very low, but nevertheless, the guidelines are to remove any polyps.
Now, when you look at polyps, the first like I mean, so it's two things that we look at, right?
Yeah.
There's always like we look at the we have like the surface pattern and the vascular pattern, right?
Yes, yes, absolutely.
So and surface pattern we look at in white light.
Yeah.
Yeah.
And NBI as well.
Yeah. The MBI is for the microvascular pattern.
Okay. Yeah.
Yeah,
Well,
that's like this is why we distinguish the two, right?
Yeah.
So in white light or TXI that you're using here, first you look at the surface pattern, you see that the surface is regular,
Mhm.
you know, you can identify like measure the size and so on. And then that's when you switch to MBI to
The vascular
investigate
yeah.
the microvascular structure
Yes.
to tell like, okay, is it like, normal structure? Is it like branched out vessels? Is it like totally amorphous?
Mhm.
Well, in the surface pattern there, you're looking like, okay, do you have regular pits, brown pits? You have the
Tubular
vesicle,
pits,
one thing that I did not see you doing here in this during this polypectomy is that actually was switching to MBI to look at the polyp from close up. So that would be the first thing I would like tell you. Like it was quite easy to tell with white light, of course.
Yeah.
But one thing that I think that you should always like switch to MBI.
Absolutely. It's there's two things in that polyp. It is the localization of the polyp. It was if you see now it is in front of you, but I mean it is around 11 o'clock from the scope. So it was a tricky. I did lose that polyp at some point, so I came back and took it. That's why when it comes to this point, you just this has to be taken away, and this is going to go to analysis.
Yeah.
I mean, in educational purposes, absolutely, it is something that you have to examine in two different light settings. Absolutely.
Yeah, I don't think the thing is that's the thing. It's like I'm an educational person, but I think it should be a part of like your daily
Practice. Absolutely.
practice. That like always like you use everything, all the modalities at your disposal, in order to make the best judgment, right?
Absolutely.
I think that's one way of looking at it.
100%.
And like I think you had a very like I mean, do you think like so if we think about like the positioning of the polyp, is it in the perfect place for you to do a resection here?
I mean, it's not 100% perfect place, but I did have control of the scope. But I mean, it was easily, you can easily lose control of the scope. So,
Right.
So I mean, it is a small polyp and it's always a judgment. And in that judgment, I thought, you know what, moving the patient and trying to correct the scope would require I mean, it would
Take some time, right?
take some time, exactly.
It's always racing against time.
So I'm like, yeah, this is good enough, I would say, to radically excise this polyp, basically.
Yeah.
So it is not the optimal position, absolutely not, but it was good enough to take this polyp radically.
I think so too. Now choice of snare. You asked for a snare. What do we have? Like is this was I think a 15 millimeter
Yes,
snare.
that's correct. Oh.
Yeah. So how do you think in terms of choosing your snare? Do you like what would be your, let's say you have unlimited resources. What would you select for this polyp?
I would say 10, which should be more than enough and better control for this
A
polyp.
10 millimeter
Yeah.
and a dedicated cold snare, I would
Yeah,
say.
absolutely.
Yeah.
It's not a hybrid snare. This is a
Yeah,
hybrid.
a hybrid. Yeah,
Just
and the difference is like the thickness of the wire, right?
and monofill, exactly.
Yeah.
Yes.
So maybe do you use the monofill, or you see like there's this compact wire technology now.
Yes.
Braided, but they keep the quality of the monofill.
Yes.
Yeah, like
and it is sharp,
sharp, crisp
Yes.
cut,
Yes.
quicker cut,
Absolutely.
less traumatic, and you do not risk like, actually having to do the cold avulsion technique where you have to tug at it if you get too much submucosa. So yeah, but I understand sometimes like, we're limited with resources and but we have at hand,
Absolutely.
So I would choose a 10 millimeter snake dedicated cold snare as well for something like that. And usually, they come in like either the oval shape or the hexagonal shape.
Yeah, absolutely. This is, and I think the oval shape I think is most appropriate for this one. Hexagon, I'm not sure if in my experience, it is appropriate for bigger polyps and and
Yeah.
it
It
is
really depends, right? I mean, many of the hexagonal ones, they kind of they allow you to kind of get these uneven edges. But like again, I mean, really it doesn't matter as long as you have good tip control, as long as you have good
yeah.
placement.
And then what do you think the most vital part is in the size of the polyp? Is it better control you get, or
The size of what? The polyp?
the size of the snare?
I mean, I always try to choose the snare that is small, almost smaller than the polyp that I have.
Okay.
You know, like, you don't go for, I don't go for, like, if I have, let's say, a polyp that looks like it's 15 millimeters, most probably by, like, getting good around it in a nice way and doing a good lift, you probably can, and sometimes you're using underwater technology, underwater technique, you probably can remove the whole thing with a 10 millimeter snare. Yeah. So less, I try to like go for the smaller snares rather than the bigger ones. And I almost never use more than 25 millimeter snare, because that's when you risk grabbing muscle and causing, like,
Absolutely,
other issues.
How about inflation or deflation? Is it the thing is the more inflated you are, insufflated you are, basically, is the lesser tissue will grab, isn't it?
You're less tissue and you're gonna have more wall tension.
Yes.
Right?
Yeah.
So the idea here, like at one point there, when so I think it's right here, when you put your snare out and you were about, like, I told you, no. Here, remember?
Yeah.
I told you, no. You need to get back. You need to go closer to it. Because why? You have like the sheath, this white sheath that's sticking right out of the scope. In order to get the polyp the best way, you need to get as close to it as possible. Just get it right in your field of vision. Okay.
Yes.
And then what you can do, you can actually ask your assistant to open the snare already while it is still inside the scope.
Okay.
Ask them to open it still inside the scope as you push it out, so that when it pushes out, you put the tip of your scope like above the polyp, so that when the snare comes out and it's open, it will just hug the polyp. Right? And then you can cut it nicely right away. So here, like, I tried to open it before you came out. It was a bit too slow at that. And then, like, I tried to open it less, because this is the thing with the bigger snares. The bigger they are, the more, like, they open more like in a rectangular shape rather than an oval shape.
Yeah.
So, like, you almost always need to open it more.
Yeah, you're right.
It makes the
Yeah.
control a bit difficult.
Yeah.
And in terms of like insufflation and desufflation, I always try to, like, get around it. And then this is the idea, like, you need somebody to hold the scope for you. Ask an assistant, hold the scope for you, so that you can actually control the tip with the tip of the scope, and so that you can work with your snare. And in this stage like this, you have somebody holding the scope at the anus for you, and a certain torque. Sometimes you need it to hold in a torque, right? Yeah. So that you don't lose it. You lose it, you fall, you lose
exactly.
position.
Yeah.
So you have them hold it for you. You're holding the scope, and you can push it in, and you just, like, you want to push it into the wall, right? And when you're pushing it into the wall, you need to desufflate. You need to empty from air. So you desufflate and push in, and only then you cut. I mean, this is a very soft polyp, right? Didn't need much, but you need, like, you push it into the wall and desufflate, and only and cut then. And that's even more important when you're doing hot snare polypectomy.
Absolutely, yeah, because you want exactly the right amount of the polyp.
Right amount of the polyp, and then they have other safety checks that you can do. Make sure that you're not tugging a muscle, by pulling at the snare. You need to not over inject, so that the wall is not too tense. And then the last, like, so this polyp was removed nicely. And what do we say here? So now you removed it. You need to see, like, is it gone or is it not gone? And one nice way of doing this is, like, switch to MBI and just put a lot of water on it. Just drown it with water. And you're going to see this beautiful submucosa right under it, with the vessels and everything. And you know that your polyp is fully removed, and you're happy with that. You take a picture of this. If a patient gets post-colonoscopy colorectal cancer for whatever reason, it's not because this polyp has grown back.
No.
Something else.
Absolutely, yeah.
Right?
No, but I agree with you. And then you see it is now the size of the polyp is more very clear, especially when you do the.
Yeah, it's quite small, right? I was like, I
Quite
think
small.
it's probably 5-6 millimeters. It can be more than that.
The other thing that I think technique that I usually do is I try to go identify the polyp, and after I identify the polyp, I try to just look above the polyp, take the tip out, and once I take the tip out, I slowly ask my assistant to take out the polyp snare.
Yeah.
And once it's halfway out, exactly about 1 to 2 millimeters above the margin of the polyps, I usually try to adjust fine adjustment of the snare so it lies exactly like an eye shaped on the polyp.
Yeah.
And then I suck a little bit and I stop the size of the polyp. So it's not more, you don't take more out of the polyps than when you need. So you somehow you customize it to less than 10 millimeters polyp space snare.
No, that's a great idea. I think that's a great idea. But like, in the colon, one thing that is good to think about is they'll try to always like take more, like, take more of the healthy tissue. In
Exactly.
doubt, always take more because
100%, because you want to be safe. Yeah.
You want to be safe.
Yeah. And the other thing is you do need a very skilled assistant to help you out, to be sync with you. Otherwise, this is not possible. Otherwise, you're going to have to do, like you said, you're going to have the assistant hold the scope and you do the maneuver yourself.
Yeah, you need the assistant because that's when you need to always like have this check-in with your nurse and like so that you have this understanding of what you're doing, right?
Yeah.
So it's training the assistant on not only seeing the polyps, but like, okay, how are we going to remove them? What are we going to do with them? Right? So I think this is one the take-home message. I think this is very well done. Like, technique-wise, don't need to talk about. I think it was really good, but like in terms of like just the polypectomy, I would say that the only thing that I would suggest is that try to work closer.
Yeah.
Sheath closer to the tip of the scope. You already have your distal attachment that is keeping everything in place. So I think that is just an additional little thing that
absolutely we all need to improve a little bit. One more thing for this polyp, it is microscopically radically excised. But what would you say about the control for this type of polyp? I mean, this patient has I mean, this is going to be sent to analysis, and given it is low-grade dysplasia.
Yeah, I mean, I think it's not that what's going to happen is like it's going to be low-grade dysplasia. This patient had some history of colorectal cancer in the family. It's not super clean, right?
No,
Yeah.
not super clean.
They say that they have removed some polyps before. We're not sure now what happened exactly. We don't have the report. I mean, if you follow like the guidelines strictly, then they would say like, one polyp, one adenoma, less than 10 millimeters, back to surveillance, right?
Yeah, but they're having a gray
here,
area with this
but
clean colon, basically.
right.
Yeah.
Yeah. And here I think we end up like in this gray area with like guidelines that are just supposed to guide us. And in a patient like this, I mean, his age, 6 years old, history of colorectal cancer, they've removed some polyps before. We don't know what they've removed. We saw this one polyp here. We're not sure if we have seen everything. Maybe we missed something because it was not that clean. So I would opt for the safe side, and I would rescope this patient in 3 to maximum 5 years.
All right.
Yeah, probably I would
do 3.
I would scope it just because like I don't know. Or the other option is because we may think that like, okay, this bowel prep was not very optimal and we need to actually ensure that there's nothing else, is that we just plan another one within 6 to 12 months to ensure that there is nothing there. And then if nothing is there, patient is back to regular surveillance.
That's correct.
And that's what I think.
I 100% agree with you, and I think that's a good guidelines.
Yeah.
It's individual, as I said. No, but good tips, Doctor.